Yeah, hi, good morning, and welcome to the webinar from Project Hope. Thank you so much, James and Jeremy. In fact, I was warned by my colleagues that going after Jeremy is not going to be easy, and so I'm going to try my best to use the next 10 minutes to talk about how we took all the great work from Jeremy and as you mentioned that kind of spread that good work through our global network. And so I also want to thank my colleagues, Ravan, who's our program officer in mental health here in Washington, D.C., and she and our colleagues who have been working on this. And so I'll be presenting on their behalf. So in the next 10 minutes or so, I think what I want to do is I want to convince the audience with two things. One is this unique collaboration between New York City Health and Hospital and Project Hope has solved a very large global health challenge. And I think hopefully, the slides ahead will kind of reflect on that. And the second thing is that impact of that collaboration on number of lives, as Jeremy said, saved or improved quality of care. And so I hope those two things will come across as I present my slides. So let me go. So just to kind of start with the background on Project Hope, we are, our mission is to place power in hands of local healthcare workers to save lives across the globe. And I think what we are talking here about mental health directly kind of reflects in our mission on how we see the importance of healthcare workers. I mean, in fact, I go back to my management school, and if you're spending 60% of your organizational resources on human resources, they are the ones who should be cared for the most. And so, as Project Hope, we do value their contributions and how we can help in that regard. So as the Project Hope is it's a 60-plus-year-old international health and humanitarian organization based in Washington, D.C. And we have kind of 5 program focus areas across our global outreach where we are working on pandemic preparedness and response. We talk about burden of disease. In Africa, we talk about HIV/AIDS, MNCH, maternal newborn child health. We also work on disaster, whether it's domestic here, natural disaster, health crisis. We are actively working in Ukraine, and also we have you may know the peer-reviewed journal called Health Affairs that we run at Project Hope. So across those areas, we look at mental health and how that can be helpful. Another map just to show where we are globally. We in 2021 we worked across 37 countries, all the way from China, Indonesia to this side of the continent where we are actively working Mexico, Venezuela, and so our outreach across those countries with 92 health programs in 5 program areas. But how do we work in these countries? I mean, of course, we tailor our intervention to what is needed in the country, and I think that's where, again, we look at our mission of working with healthcare workers and improving their skills and support in kind of areas that they want to work on. We form strategic partnerships. I mean, this is a good example of working with New York City and Health and Hospital about how we can create long-lasting solutions. We also generate evidence-based solutions in the field, and lastly, through our global network and technical expertise, bring out long-term changes. And we have we look at the 5 drivers of health inequity that we are interested in addressing. Of course, we look at climate change, displacement of population, mental health, global health worker shortage, and equitable access to care. And so, as today's topic is very important, whether it's a global health workforce shortage or mental health, or even the impact of climate change and displacement on people's mental health issues. So, with that, I want to talk about more about how we took the tools from New York City Health and Hospital and scaled up to kind of this global implementation plan. And we cannot thank our, the funding support that we have received from our donors to do this work. uh, but I think, as Jeremy mentioned, I think it was good to see the visibility that we are getting for mental health issues across health workforce in the U.S. But I do worry about how mental health issues are addressed in other parts of the world, especially in the low middle income countries where there's a huge taboo about what mental health is. It's mostly you don't talk about as a strong person. So mainly if you think about in rural areas of Africa where a healthcare worker or a doctor is seen as one of the senior person in that district, they can't talk about weakness. And so I think it is I do feel like that we are on a different scale when I think about how things are happening in New York City. But I think the path is towards what Jeremy presented, but I think we are a bit farther away and we need to do a lot. And I think this collaboration is helping us to bring that population to that. I just wanted to start with some global epidemic data. I mean, there are a couple of things. One is, there's a physician foundation. Of course, this comes from the U.S. data, but I think Jeremy also presented some of this. I think my interesting data point here is that only 14% of doctors sought mental health support in 2021. I think that's a big number. And when I look at the International Council of Nursing study, 80% of nurses globally were affected by pandemic, and I think that's very obvious in how COVID-19 has affected everywhere. But one thing I wanted to mention is that pre-pandemic, I think there was a huge discussion about global shortage of healthcare workers, and then during the pandemic, there's an estimated WHO figure of like 80 to 150,000 people, healthcare workers dying due to COVID. And so I think the COVID-19 has just, I would say, created more healthcare worker shortage, as well as the burden on the limited staff has increased, which has also affected how people have felt burnt out in these health facilities. I think another critical area in the global health is the lack of access to protective gears, clinical guidance, and vaccination. I mean, I think we all know about inequitable distribution of vaccinations. There was the latest figure of 1 in 10 healthcare workers in Africa are vaccinated for COVID-19, and so I think we are far away from the numbers that we see in the Western world. And very importantly, I think the last point, which is 70% of direct patient care healthcare workers are women, and I think it also talks about the gender equality and I guess inequality in this case, about like how the front line healthcare workers, being women, are the ones who need more help from the organizations, like what I hear from the New York City Health and Hospital. So we took the training program that Jeremy and his team has developed, and we actually went across 37 plus countries on taking a approach where we created a framework where, again, this Hero NY original material that we were given by New York Health and Hospital, we identified local implementing partners in each country. And so this was a very important step, because we wanted to make sure that there are right organizations that are taking these tools and helping us, not just do a one-time training, but also make it a sustainable approach. So we wanted to make sure that the partners are selected carefully. We also made sure that we have right stakeholders in those countries. So, definitely the Ministry of Health, the universities, academias, those who are mental health experts in those countries are part of our engagement in that. And very importantly, we just didn't want to take something from New York City and give it to somebody in Addis Ababa, but we wanted to make it sure that it's a culturally appropriate training. And so we spent a lot of time on making sure that it is culturally appropriate. Of course, these materials were translated into local languages, and then the main approach was to training of trainers. And so there was a lot of planning that was done through that. And then finally, it was the actual delivery of trainings. And then there was a main component of it was to kind of make sure that we're doing some baseline assessment of mental health issues, and then we are doing some post-assessment of how people thought about these trainings going and what can be improved further. So as I mentioned, we did baseline assessment. Again, some of the data, as Jeremy, you presented in New York City, is very, I would say not at, we don't have that kind of data, baseline data, and so it was very important for us to create that. We also did 9 focus group discussions across 5 continents, subcontinents: Latin America, Southeast Europe, Southeast Asia, and Africa. We had key informant interviews, and of course the data we had qualitative as well as quantitative data collected through the assessment. I guess we just wanted to give a quick overview of what we identified in baseline needs assessment, and I think of course the challenges were very similar to what Jeremy you presented in your assessment. But I guess one of the things that I see, and growing up in India, the coping strategies in many countries is to have a social support, work with families and friends. But you can think about in COVID-19, in quarantine situation, you are isolated. You're not allowed. You're not going to your family. You're not going to your friends. And so I think it was a very interesting to see that the coping strategy that works in those cultures was not available. And of course, another thing that I wanted to highlight is that there are no financial resources to go and get mental health services in many of these countries. Like here in the United States, we are very privileged to have insurance companies allowing us to access therapists. But I think that that's another big challenge I see in working in developing countries is there is not a system, as well as there's no well-funded available mental health services. I guess the last thing I wanted to say is that there's a huge need for greater financial resources. I think I'm just looking at time. I'm going to go a bit faster, but I think these are the local implementing partners. I think we were very privileged to have Africa CDC work with us in African countries, and we through them we partner with them. As I mentioned, we translated this in 20+ languages, and you can see that how these translations are, or whether they are available on our website, and anybody can access these. These are the examples where actually we did conduct field visits to make sure that the trainings have gone well, and Ravan was the one who was participating in these trainings. One thing I wanted to mention is that 68,000 healthcare workers benefited from the work that New York City Health and Hospital has done. And so you can see these numbers across the continents where these training of trainers was happening. Again, just to give another number, 7,500 plus master trainers were trained through this training program. 60,000 plus cascading sessions happened, and there are 400 plus healthcare institutions that were benefited from, again, the work that New York City Health and Hospital shared with us. And another important point I want to mention is that 71% of female healthcare workers got access to this mental health trainings through our intervention. We also conducted an evaluation, and again, 90% of participants found this useful, was relevant. Of course, I think they always kind of thought that there should be more time spent on some of these tools. But again, that's something that can be thought about in future. We also have plans for 2023. There are new countries that we are going with the intervention. And again, going back to our initial point on sustainability, we are looking at not just one-time training, but more about how can we have a long-term impact of these trainings as we are trying to build this mental health area in the global health setting. So with that, I'll stop here and hand it over to James. Thank you.